Bismillah ar-Rahman ar-Rahim. Our case today is very interesting. This is 1 month old girl, preterm, ex-preterm, 23 weeks, 500 grams, admitted due to RDS. Now the baby is 1 month, is chronic lung disease or BBD. Our questions now are struggling to maintain the saturation for this baby. All the time the baby saturation is 70s, 80s. We cannot reach to target saturation for this baby is 88 to 92, and unfortunately we try many times to give DART twice, but still the saturation is not maintained. So how to improve the saturation in chronic lung disease? By 6 ways. The first way, actually, you have to improve the worsening condition or acute cause for deterioration. Like if the baby is having a pneumothorax, you have to do transillumination and chest X-ray to rule out air leaks. Second, sepsis, you have to take septicurgab, start antibiotic. If the baby is antibiotic, you have to upgrade it, and the cool infectious disease, actually it will help you. The third issue, if the baby apneic, bradycardic, so this is problem with respiratory drive, so you have to start caffeine. And also if there is any seizure, you have to start antibiotic medication and consult a pediatric neurology. The second way to improve the saturation for chronic lung disease, optimize respiratory support. Check the baby in non-invasive, put him in invasive. If invasive, conventional, put him in high frequency. Our patient is in invasive and conventional mechanical ventilation, so we need to optimize the setting for lung recruitment. You have to increase the PEEP, prolong respiratory time, adjust oxygenation, and you have to accept permissive hypercapnia. So the accepted blood gas for this baby, pH it will be 7.25, and BCO2 we have to accept 60 to 65, and try to avoid excessive hypoxia. Excessive hypoxia is leading to multi-organ failure and increased mortality. The third way to improve the saturation, chronic lung disease or bronchopulmonary dysplasia regimen. As we know the lung recruitment, as we know the pathology for chronic lung disease, decrease compliance and increase resistance. So we need to increase the PEEP, prolong respiratory time, decrease the rate, because due to poor compliance and airway collapse, so we need to improve this actually the lung compliance and decrease the airway resistance. Try to avoid during your lung recruitment hyperinflation. Just we need adequate blood gas, not perfect gas. The fourth way to improve the saturations, the supportive treatment. If there is anemia, you have to treat to keep the hemoglobin more than 10, and perfusion if you need any drops to maintain the temperature, maintain the electrolytes and the blood sugar. The fifth way, the medication. 4D, we have to give dexamethasone or DART protocol, diuretics and dilators or bronchodilators, and diet, nutritional support. DART protocol, you have to start it in such cases. Diuretics, you have to IV like Lasix or oral like spironolactone and hydrochlorothiazide. If they don't give Lasix for a long time, lead to nephrocalcinosis, so you have to start spironolactone and hydrochlorothiazide. And also dilator, bronchodilator like caffeine. And diets, you have to increase the calories and decrease the fluid, restrict the fluid, and for sure you have to consult the pulmonologist. It will help you in such cases. It will give the Ventolin or Pulmicort, CBT, suctioning, and might do CT to looking for interstitial lung disease as complications. So the sixth way to improve the saturation, multidisciplinary team, you have to consult the pulmonologist, as we mentioned, to rule out other congenital structural abnormalities, and also the cardiologist to rule out hypertensive or right-sided hypertensive. So we are struggling with the baby to improve the saturation. How to improve the saturation? By 6 ways. The first way, this is the key point, the message from the case, to improve saturation, or if you are struggling with to improve the saturation for premature babies or chronic lung disease, 6 ways to improve the saturation. The first one, you have to improve the worsening condition or acute deterioration like pneumothorax, sepsis. If there is apnea or bradycardia or affecting respiratory life, you have to start caffeine. If there is seizure, you have to start anti-epileptic medication and consult a pediatric neurology. The second way, optimize the respiratory support. If the baby non-invasive, put him invasive. If invasive, conventional, put him in high frequency, and you have put in your mind to increase the PEEP and prolong respiratory time and adjust oxygenation, and you have to accept a permissive hypercapnia, pH acceptable 7.2, and BCO2 it will be 60 to 65, but avoid excessive hypoxia is leading to mortality, increased mortality, and the hyperoxia is leading to ROB. The third way to improve the saturation, the bronchopulmonary dysplasia regimen, as we mentioned, the ventilatory setting, to increase the PEEP for lung recruitment, to increase the PEEP and prolong respiratory time, decrease the rate, because we know that the pathology is of the chronic lung disease, decrease compliance and increase resistance. But try to avoid hyperinflation. Just we need adequate gas, not perfect gas. The fourth way, the supportive treatment. If there is anemia, you have to treat it, perfusion, to give dopamine, to maintain the temperature, and also to maintain the blood sugar in normal level. Medications for diuretics, DART or dexamethasone diuretics, and dilator like caffeine or Ventolin, and also diet to increase the calories and decrease the fluid, restrict fluid. And the last, multidisciplinary team. You have to consult a pulmonologist, the cardiologist, the neurologist, based on the condition of the baby. ومن أحيا فكأنما أحيا الناس جميعا. شكرا، سلام عليكم.